Survive and thrive. Maximize learning in the clinical setting. It's your first day of your clinical clerkship. You've been assigned to medicine and have just met your team. The senior resident welcomes you and asks you to share a little about yourself. Your interaction with her is brief but pleasant. You are excited to officially begin your first day on the wards. You then hear,
"Okay, let's go see some patients. Put your roller skates on. We have 12 patients to see in an hour before the morning report. Then expect to admit your first patient with Jackie, one of our interns, since we're on call today. Make sure to get to your noon conference early so you can grab some lunch. You'll be starting with the other interns and see first step for admission. Okay, Jackie, tell me about Miss Miller."
Miss Miller is our 50-year-old alcoholic encephalopath, found down, admitted from ED. We've reinitiated her lactulose and treated her anasarca and awaiting dispo. Overnight, no events except for a few runs of Bigemini. This morning, eyes 1500, O's 1400 milliliters, BP 100/70, pulse 90, respiration 20, Tmax 37.4 Celsius, T current same. Asterixis improved. Abdomen distended, bowel sounds present, positive shifting dullness improved since yesterday. In summary, Ms. Miller is improving and dispo pending. By problem: liver failure, backed on lactulose, diuretics on transplant list, no alcohol for 2 months to date. Bigemini, she's asymptomatic now, but her BP is borderline low for her. Baseline is typically 110/70. Dispo, patient came from an SRO. I'll just check with our social worker if she can return. There's no family in the area, and we need to make sure her Medi-Cal is still active.
Okay, great. I just saw a text page about a new patient in the ED. Why don't you both go down and start evaluating him, okay? You have a 25-year-old male with CF, presenting with fever, productive cough, and was sent from the clinic in respiratory distress. Call me if you need me. I'll be down after speed rounds. Go.
if you were like most third years, you would probably be thinking, what just happened? You may be thinking back to your lectures, racking your brain for anything that can remind you of what anasarca is. You know you heard that somewhere, but can't recall what that means or why it's even important. The entire situation, despite lasting less than a minute, has left you wondering, is it always this chaotic around here? Not to mention, it's your first day and already you were asked to evaluate a new patient. The senior knows you've never done this before, right? For most medical students, the transition from classroom to clerkships is met with excitement and anxiety. Clerkships require entry into a new, high-stakes learning environment that can often be intense, demanding, and overwhelming. Surviving and thriving in the clerkship requires recognition and preparation for many of the differences you will encounter in the clinical setting. Among these include increasing demand to understand and retain a high volume of complex information, translating this information to clinical care, and balancing patient care with care for oneself and one's own learning needs. In the clinical years, the learning environment transforms. Teaching, once directed towards your needs, shifts towards a greater emphasis on patients. Learning, once primarily achieved through textbooks and lectures, becomes secondary to the learning that occurs through patient interactions and membership on a healthcare team. As a result, learning strategies successfully employed in the classroom simply don't work as well as they used to. Fortunately, there are evidence-based strategies to help medical students like you survive and thrive in the clerkship setting. This module has been designed with those in mind and is intended to ease your transition into the clinical learning environment and help you develop new strategies to support your learning in several key areas. This is the first of 3 modules and will serve as both an overview of the topic and as preparation for your upcoming small group discussion. Subsequent modules will be released during your transition to clerkships. There are several core learning priorities for students in the clerkship years, and figuring out just how to accomplish these requires the skill of metacognition, or being able to think about thinking. Metacognition describes an individual's ability to separate him or herself from her own thinking, to observe it, and to recognize where opportunities exist for the use of more effective learning and thinking strategies. When you think metacognitively, you are aware of the learning process itself. You are aware of the strategies you have used to control your attention, improve your memory, and organize or conceptually understand the information presented to you. Such metacognitive capacities allow for better planning, goal setting, self-monitoring, and self-assessment, skills you will be required to use and refine in your third year. The translation of classroom knowledge to patient care requires a complex, integrated understanding of the concepts learned in the pre-clerkship years. Using metacognitive skills can help you control and monitor the information you're presented with, rather than become overwhelmed by it. Mastering something like our opening case of Ms. Miller takes time, but having some pre-selected learning strategies can reduce that feeling of being overwhelmed. Metacognition is a primary component of clinical expertise, a skill that requires all forms of thought, deliberate and conscious, known as System 2 thinking, and unconscious and rapid, or System 1 thinking. According to Mark Quirk, AMA Vice President for Educational Outcomes, metacognition is the underlying thought process of experts that enables them to learn from experience and act from intuition. So how does metacognition relate to your learning, and why should you care? Pre-clerkship learning is important, and each of you has become quite adept at it. In less than 2 years, you've learned a new vocabulary, research methods, biostatistics, and biomedical, social, and behavioral sciences, which all provided essential foundations before your transition to clerkships. To manage all the information being presented to you, you have likely employed several strategies. In the pre-clerkship years, the content of the material to be learned is often concrete and requires the discrete and focused learning strategies seen here. During clerkships, however, both the content and context of learning differ. Content learned is case-based and patient-dependent, and the primary focus turns to service rather than direct instruction. As a result, students like yourself must direct their own learning experience, rapidly seek out high-quality reference information, observe policies and procedures to understand workflow and role expectations, which vary from clerkship to clerkship, and adapt to the uncertainties of disease management and patient care. You have already learned a great deal of medical knowledge, but as one recent third-year medical student colleague shared, knowledge lets you speak the language, but doesn't prepare you for the work. Let's return to the example of Ms. Miller, the 50-year-old woman with alcohol dependence and liver failure. How can you even know where to start learning from her? There are at least 4 core metacognitive behaviors that promote learning in this type of situation. These are conceptualization, critical reflection, self-directed learning, and critical thinking. When you make connections among ideas, concepts, and details, you are engaged in a process of conceptualization. Conceptualization includes specific techniques such as building mental models and creating visual images that emphasize connections between key concepts. Such active, creative, and often visuospatial learning activities are useful in that concepts can be organized according to their hierarchical relationships. With Ms. Miller, there are a number of core concepts you could begin mapping out. For example, you might create a concept map for liver failure that includes leading differential diagnoses, expected lab values, evidence-based interventions, and common complications, all integrated with what you have already learned about liver pathophysiology and chronic alcohol dependence. You might even create a master file of concept maps you develop over time to help you understand the most common diseases like congestive heart failure, pneumonia, or COPD. In addition to developing a greater understanding of the pathophysiology of liver disease, you can also learn from Ms. Miller through the process of reflection. Critical reflection can be thought of as a stepwise process of reframing and analyzing an experience based on new information gathered, input from others, and your past experiences in order to learn from it and develop a plan for future learning. You will have already most likely had a good deal of practice with the skill of reflection, but critical reflection in the context of ward medicine can look quite different. It is true that there are seemingly endless events you could reflect on and nearly always multiple layers to try to tease apart. Most students are reflexively drawn to their failures or things that just didn't go so well. We can and certainly should learn from those sorts of events, but we should also reflect on our victories. One such strategy to promote critical reflection is modeled after the clinical SOAP note. Here, you work through a series of steps that ask you to consider the content, process, and premise of a situation that triggered questions or concerns for you. Seek out additional information to help you understand what happened, create a summary of what was learned, and devise a plan for how to use this information the next time you encounter a similar situation, patient, or disease. With so many day-to-day experiences from which to draw, it can be challenging to decide what experiences are worth reflecting on. What we have found, however, is that oftentimes, those situations in which you felt challenged, uncomfortable, or unprepared, the ones that may feel best left in the past, usually provide the best material from which to learn. Rather than blame yourself for not knowing what was happening with Ms. Miller, you could consider your colleagues' perspectives and remind yourself that no one expected you to have a complete understanding of medicine, but rather to observe and gather data to support your learning. The process of critical reflection also requires intensive and impeccably organized self-directed learning. Self-directed learning involves specific strategies of honest self-assessment regarding what you don't know and where you are the weakest in medical knowledge or skills, setting realistic learning goals for each clerkship and every team. This includes thinking about what you can learn from every resident, attending, nurse, and other team members, directly or indirectly, and how to prompt explanation through good and appropriately timed question asking. Selecting learning goals, then using medical informatics to find high-quality, evidence-based sources to answer your questions, and learning from every patient you see, perhaps by identifying the top 3 take-home messages from each patient. The fourth skill you'll be asked to call upon is your capacity for critical thinking. More than ever before, medical interventions are based on medical research. It is important to determine the validity of the research you come across. Good patient care requires careful and rational consideration of all the alternatives, a behavior and skill that requires excellent critical thinking skills. Usually, this involves staking a claim and a hypothesis, judging the credibility of sources that both support and refute your hypothesis, weighing the validity of the evidence, and finally, making an informed decision. Although such forms of critical thinking are most often practiced by seasoned physicians, critical thinking can, should, and does occur at all levels of learning and through every interaction. In your clerkship, it is a skill that can be practiced to improve patient safety and patient-centered care. So let's pull all of this together and go back to our MS3 and Ms. Miller. With these 4 learning strategies in mind, here are a few tips a learner could try, employing metacognitive strategies we have just discussed. Remember that we will dig deeper into each of these strategies in subsequent parts of this module, to be released just before and after your first clerkship. Conceptualization. Create a concept map that helps you understand the link between risk factors, pathogenesis, differential diagnosis, related lab tests, and treatment. While there is great pressure to focus on lab tests and pharmacological interventions, remember the relevance and importance of social and behavioral factors too. Is she ready to cut down or quit drinking? Does she have social supports to help promote adherence? Or how does her living situation alter the discharge planning process? Reflection. After hearing about Ms. Miller, consider your subjective reaction to her so-called self-destructive behavior. Were you irritated? Did you feel helpless or hopeful? Would you call her an encephalopath? Why did you respond the way you did? How can this enhance your learning about yourself and your patients? What insight will you be able to provide the next time a patient with liver disease or alcohol dependence is admitted? Will you feel differently? Remember to write a SOAP note and include a plan. Self-directed learning. You don't know what asterisk 6 means? Write it down and develop a search strategy later. Uh-oh, there are over 52,000 hits on Google. Refine your search strategy and consider how you will filter or prioritize results. No one expects you to know everything, and your attending and clerkship directors often recommend to students to have a few learning items each day to look up. All you need to know is that the information is available. You just have to find it, filter it, and evaluate it. Online resources such as texts, UpToDate, MD Consult, PubMed, and ACP resources are other helpful paths to pursue during your quest for learning. Critical thinking. Consider what actions had to be taken and what decisions were made for Ms. Miller's admission forward. Why did the team make the decisions that they did? What was the rationale? What does the literature say about treatment for liver disease among alcoholics? What else could have been done, inpatient or for long-term management of her illness? Remember to always think about your thinking and identify areas for improved care. Being a clerkship student is far from easy. There are many demands that may seem contradictory to the dual objectives of learning while providing excellent patient care. The clerkship experience will represent an important shift in learning that, if prepared for and thoughtfully considered, will provide new avenues to meet these demands and enhance your learning process. As you prepare for your next small group discussion, we hope you'll consider some of the concepts reviewed here. And remember, in subsequent parts of this module, we'll introduce you to more specific practical strategies that can maximize your learning on the clinical setting and help you survive and thrive.